Good morning to all of you. I wish you all a happy new year as we go into a year where COVID has come back to us again, this time in the shape of Omicron. We have been asking the question, how has COVID impacted other essential health services, particularly what has been the impact of COVID on HIV? And today I wanted to share with you some of my insights and information that we've been able to collect in the WHO Southeast Asia Regional Office on what has been going on with COVID. So I'll start with the first slide just to give you a screenshot of where we are with the impact of COVID in our region. So COVID has been, of course, very, very wave-based. It's not been a steady, linear pandemic. And we are now in the fourth wave of the pandemic in our region. If you look at the purple lines, those are the Southeast Asia region. And what's very clear is that we are continuing to see a continuing increase in Omicron-driven as well as Delta-driven pandemics in our region. These data are till the 20th of December 2021, but since then there has been an exponential increase of COVID in our region. Now, with COVID came national lockdowns, and this is a map that is showing you what kind of national lockdowns were implemented in 2020 in our region. And what's notable here is the overall blue in Southeast Asia and South Asia is really very, very significant. And these are national lockdowns, often meaning no flights, no schools, hospitals where we're only doing essential programming, people were not allowed to move around at all. So in a way, national lockdowns was the most important and widespread response to the COVID-19 pandemic in 2020. Since then, we have more sophisticated measures of the severity index of public and social health measures that were implemented. And these PHSM severity indices are based on a combination of 6 things: masks, school closures, business closures, restrictions on gatherings, restrictions on domestic movements, as well as international travels. The darker the color, the more severe the measures in that country. And again, we can see that in India, in Thailand, in Indonesia, generally speaking, the measures were not amongst the least severe. They were on the stronger side. So what was the impact of that on ARVs specifically? And I know that I'm going to be talking more broadly about HIV services, but I want to focus first on ARVs as a critical part of treatment and care. At the beginning of the COVID pandemic in our region, so I'm thinking now of the first and second quarter of 2022, the Indian government, which is a very big producer of ARVs, proposed to put in a ban in place for the sale of ARVs and the export of ARVs to other countries. And this, of course, created a major panic. There was a lot of discussion in the country, and within 2 weeks, this was rescinded. However, there were still a lot of challenges around the manufacturing and supply of ARVs. And unlike what has been the case for some other drugs, where the API itself was not available, in India, the big challenge was really that the lockdown was so severe that there was reduced workforce in the plants. There were no people to load the trucks. There was no packaging available. So ground transportation to reach the warehouses was a really big challenge. And even though the government had been clarifying that essential goods would not be hampered in transportation, this led to a big challenge. The other thing which is not so often thought about is packaging material. There was a complete dearth of packaging material and printing to be able to put in place the product inserts. And reduced movement of cargo flights. This meant that, of course, we were not able to get things to countries by plane. In our region, particularly in the office where I work, we were spending a lot of time getting drugs to people by road or by sea. And for example, for Nepal, we had to do the facilitation by road and Indonesia by the sea route. By the time we got to May 2020, ground transportation was a little bit more improved. So was cargo flights. And the Global Fund did an evaluation to say that the overall impact of this first big lockdown that we saw between March and May in terms of ARV supply was a relatively moderate impact. After that, we were in touch again with ARV manufacturers, and there was some recommendations that they provided for how such a situation could be avoided in the future. So before I go to the recommendations that they made, I just want to share with you these two plots. The first one is really a radar is a word plot, a word cloud, which is showing you what were the most important themes that were coming out in the conversations with the manufacturers. And you can see that they've got restrictions, they've got packaging, they've got supplies, they've got API, they've got lockdown, air, manpower. All of these things were something that came up. Next to it is a radar plot, and this is on a scale of 0 to 5, 5 being the most favorable and 0 being the least favorable. And here you can see that international shipping, as well as this KSM and other raw material, was a real problem. KSM stands for key supply material, and apart from API, this was an area where there were some concerns. There is a paper written on this, and the reference is below for those of you who are interested in understanding more about what was happening to ARV production and supply at that time. Some of the recommendations that came from the ARV manufacturers was, that really focus on stock and inventory management, have multiple sources for raw material rather than relying on one particular country. In the region, China is often the large producer of API and raw material, and that was a challenge at that time. They also talked about things like fast-track clearance, using shipping routes when flight carriers were not involved, and specifically having a more accommodative approach on pricing because of the cost escalation in freight and other aspects related to the manufacturing supply of ARVs. They also talked about opting for cartonless and leafless packaging and staggered delivery schedules. Now, in this next slide, what I want to show you is what was actually happening to HIV diagnosis and monthly ART initiation. And these data are from 5 high-burden countries in Asia, in our region, in the Southeast Asia region. And I am showing you here a comparison of the levels of testing and diagnosis at the same time between 2019 and 2020. And you can see the data presented by country 1 to country 5, and the data presented at a monthly level. So when you look at HIV diagnosis, by the time it was May, we saw a real dip in May and June in HIV diagnosis. And so it's very clear that there was an impact on testing. People were not being able to test. Access to testing was limited. And this began to improve in the third quarter of last year. And then at least in one country in the region, we saw a major dip in testing. So very significant dips in testing of up to 80% in our region was noted. Now, the other side, we are looking at ART initiation, which in a way follows the curves for testing. We saw a real dip in ARV initiation, but earlier on than we saw for testing. We began to see these dips in March itself. And in one country, that dip was almost 100% by the time we came to May. Then this recovered again in the third quarter of 2020, and we now continue to see some challenges in October towards the last quarter in one country. So the Global Fund undertook a service disruption assessment in 2020 for 7 countries in Asia. And their findings are very similar to what I've just shown you based on our data collection from the WHO Southeast Asia region. And we saw that there was a significant decline in testing in the region of around 60% in the first 3 quarters of 2020. And there was also a significant dip, slightly more acute on screening amongst HIV and TB. This was also something that was noted in these countries where these were people who were already HIV positive. So there was an impact on care amongst HIV positive when we look at TB screening in these 7 Asian countries, which are listed at the bottom of the slide. Now, WHO has also been doing what we call pulse surveys, and these are surveys on the continuity of essential health services during the COVID-19 pandemic. And you can see that, in round 1, there were more than 50%. 14% of the countries were saying that the disruption that they had was very significant. And by the time we came to round 2, there was some improvement. So in the first round that we had, 7 out of 10 countries that participated said that there was quite significant disruption. And by the time we came to round 3, this was only round 2. This was only one country that was really talking about significant disruptions. So overall, an improvement in the disruption in ARVs by 2021, and no more reports of significant disruptions. Now, in this slide, what you're seeing is that there used to be in the region a very steady increase in ARV coverage. We saw that at the end of 2019, 2020, this has hit a plateau. And this could be due to COVID disruptions, really coming from the fact that access to overall healthcare and demand for overall healthcare, because there was such a fear for people contracting COVID in health facilities, is something that we see. So if you look at the circle between 2020 and 2019, there is a plateauing of what has been happening with ARV coverage in our region. And of course, we are significantly far away from the global target that needed to be achieved still in the region. In this next graph, I'm showing you what has happened to ART coverage amongst pregnant women. And again, you're seeing that there has been an actual decrease from 63% to 56% between 2019 and 2020 in our region. And this is interesting because You're beginning to see some plateauing of this also in adult women aged 50 and over. And we suspect that this is coming from an overall decline in access to ANC. Even if ANC was happening, antenatal care was happening, they were probably focusing on the most basic aspects of ANC and not really pushing forward the elimination of mother-to-child transmission agenda. And this is a big setback in the region because in our region, 3 countries have already been certified for mother-to-child transmission, elimination of mother-to-child transmission for both HIV and congenital syphilis by WHO. Now, while I've been talking so much about ARVs, what's very clear is that the real damage from COVID, the impact has really been on HIV prevention services and HIV testing services. And the impact of disruptions in prevention services is likely to have an impact on incidence reduction for HIV over a longer period of time, unless we really get into significant catch-up campaigns. So, the main point of the slide is that while the continuation of ARVs was largely maintained in 2021, what we're really seeing is that prevention and testing, as well as hepatitis-related services, and this is important because in so many countries, people are co-infected with hepatitis as well as TB, have really been negatively impacted. And these are, again, data from the Pulse survey that we saw. And I will invite your attention to HIV prevention services, where we saw disruptions of 63% reported, and HIV testing, where we saw disruptions of 50% reported. Now, why is it really important to think about HIV services in the time of COVID? Why particularly are we thinking about this as an important issue? And in this slide, I just want to draw your attention that, the evidence is saying that HIV is a significant potential independent risk factor for severe or critical illness at hospital admission and in hospital mortality. And we also see that there is evidence emerging that the risk of adverse outcomes amongst people living with HIV is highest when their CD4 cell counts are low, or when they have detectable HIV viral loads. So what this really means, again, is that getting treatment right, maintaining the quality of treatment, maintaining adherence is critical to ensuring that that the risk of severe critical illness amongst people living with HIV when they get COVID is reduced. So getting them the right ARVs, managing adherence, supporting mental health outcomes, so that depression and other things don't negatively impact on adherence is really very, very important. So HIV services must be strengthened during the COVID-19 pandemic. What if we do nothing at all? What is the cost of doing nothing? And it seems when we look at modeling work, and this is modeling work that was done in Africa, that if you have HIV treatment interruption for 6 months, this can really result in a huge increase in AIDS-related deaths. So if you look at the dotted line, where we're projecting 580,000 deaths, within that, the excess number of deaths is 110,000 deaths from a 20% treatment interruption. Similarly, a suspension of BMTCT services for 6 months could also result in dramatic increases in new HIV infections among children. And this is something that we fought so hard for such a long time that we cannot afford inaction. We must ensure that services for both prevention and treatment continue to find high priority in what countries are delivering for their populations during the COVID pandemic. Now, it's very important to understand what are some of the reasons behind the disruptions. And the disruption is coming not only from service provision, but it's also coming from individual and community level reasons. And again, we've presented here some data from a Global Fund assessment, which is called The Impact of COVID-19 on HIV, TB, and Malaria Services and Systems for Health. And I'd like to highlight that apart from restrictions and patients being diverted to other facilities and the scope of services being reduced, we've also seen that there is reduced general health communications, reduced general campaigns to promote care-seeking behavior. We've seen that provision of specific services has been completely suspended. We've also seen reduced and changed opening hours that may not match the needs of people who need services. From an individual perspective, fear and mistrust and uncertainty of getting infected with COVID-19 from health facilities is really important. And this is something which I think is not so obvious to many of us, that our health workers in many countries in Asia don't have access to PPE. Health workers had reduced access to masks, to gloves, to sanitizer, to cleaning materials. And overall, there was a huge shortage of human resources because people were also sick in many of these facilities. So public trust in facilities, public trust in accessing the services was very, very limited. And it was not just a facility side issue, but there was a real demand side issue. The other thing to note was that there was a huge disruption in public transportation and stay-at-home orders. And that, of course, supported people's need need is not the right word, people's fears and delayed care seeking. There were also changes in recommendations to the public for how to deal with mild illness and elective procedures. So overall, it's important that in the future, because COVID is still with us, we understand that demand for services needs to be maintained as much as possible while focusing on the supply side issues. Now, what has worked in our region and what has not worked? And we've seen that, differentiated service delivery has really been a very important part of what has functioned in our region. Multi-month dispensation of medication, community pickup and use of digital health and mHealth technology has been fundamental. People have not been able to go to health facilities, and there has been a need to reduce the burden in health facilities of patients going there when they don't really need to be seen by a doctor. So use of digital health and mHealth has been really, really important. So in our region, 11 countries in SEER, one does not report HIV at all, which is DPR Korea. But in the other 10 countries, we saw all adopted a policy of multi-month dispensing of ARVs. And people were picking up were given their drugs for 6 months. There was also, a lot of countries that supported take-home doses for opioid substitution therapy for people who inject drugs, particularly 4 countries in our region, Myanmar, India, Indonesia, and Nepal, were giving opioid substitution therapy doses to people to take home for 14 days. There was also a huge focus on self-testing, and the COVID pandemic has really shown why self-testing can become so important. And this has been particularly important for work with key populations menu of sex with men, sex workers, transgender persons, where we need to continue to ensure that self-testing and prevention focus remained very, very important. So while multi-month dispensing and OST dispensing was happening, we had the big challenges around what didn't work. And what didn't work was the procurement delays. We had significant transportation-related procurement delays in some countries. And also, as I said earlier, the focus on STI services and core HIV prevention services just wasn't there. Ministries of Health just didn't have the bandwidth to focus on that. And going forward, as we live with Omicron, we need to think about how that is addressed. Now, while the ministries were talking about multi-month dispensing, it was really the communities that were at the forefront of doing the work, delivering ARVs to people's doorsteps, helping people to access food, helping people to access vaccinations. It was the community that was doing this. And unfortunately, they continued to bear the brunt of challenges with law enforcement when they were doing this work. Many of them were not recognized as frontline workers when it came to the COVID-19 rollout. And I think there are significant lessons from this pandemic around how we can really use the communities themselves during pandemics to deliver essential services. There are some examples of this from Thailand that I'm just going to share with you. But on this slide here, we have pictures of community workers themselves going out and doing the work from India, Nepal, and Thailand, and giving ARVs to people at their doorsteps. So in Thailand, some interesting work has been done around institutionalizing community-led services. And here is some work that has been done where the community lay provider, the key population peer, is provided with certification and CBO accreditation, and funding for this is then provided through the National Health Service Organization. So in 2021, this was institutionalized in Thailand with national KP lay providers being certified, and the registration for these CBOs will then enable lay providers to receive direct financial support from the government, which will lead not only to pandemic responses during future waves of COVID, but also lead to the sustainability of the CBO-led work in Thailand. So this is a really good model, and this is something that could be followed in other countries as well. So I'll conclude now and just say that we do need to move to more resilient approaches and think about how we are going to build back better after COVID-19. But we also need to think about how we will continue to ensure that the HIV program does not suffer like we saw in 2020. And multi-month dispensing and differentiated service delivery options are key to that. Maintaining a fairly good stock position of ARVs and other critical medication is really, really important. Making sure that there is clear monitoring and support provided when there are service disruptions, particularly for key populations, is really important. And communities are best placed to monitor this. Information flow has to happen between the communities, governments, and international partners to be clear about where there is need for support. And the community engagement in service delivery and treatment support needs to be institutionalized, along with a higher emphasis on health worker safety and making sure that those who are providing these services, the communities themselves, are not being left without access to PPE, access to vaccination, etc. Increased diagnostic capacity, particularly with self-testing, will be really, really important. An ongoing distribution of OST whether we use 14-day take-home models or we go with community distribution or pharmacy distribution, is going to be really, really important. One thing that we noticed in the COVID pandemic was the need for social protection for KPs and people living with HIV. Many of the transgender community in India suddenly lost access to food. We had a situation where we were being asked to provide support for housing, food, as people lost jobs, as sex workers were not able to generate any income due to stopping of sex work and lockdowns. So putting into the package some form of social protection is also going to be really important as we move forward during the COVID-19 pandemic and beyond that. So with that, I'd like to thank you all very much for listening, and I wish you all a safe entry into the new year and beyond. Thank you very much.